This is the first presidential lecture.
Absolutely. Sir, good morning.
Good morning, very good morning to every one of you. So let us make this course a very interactive course and something that is practical, something that every one of us can learn from each other. And I would really request people who are not doing ICLs or IPCL or the FAKIC IOLs very much would like to answer all basic questions as well. So let us start from basics. Let us go on to the more appropriate techniques, designs, and there are so many phakic IOLs in the market today. Of course, ICL as of today has the longest track record, which does not mean that the others with a lower track record are not as good. So you need to assess, you need to understand, you need to do it the right way, and that's what I'll be speaking about now. So the right way to do the ICL, and we all have a track record of quite a long years of doing ICL. And ICL and Toric ICL. So let's go to the basics. These are foldable phakic lenses, which are very, very thin, which means that you have to be very particular when you are loading the lens. And I'm going to show you videos of the loading of the lens. They are supposed to be in the posterior chamber, the sulcus, and that is where they have to be posted atraumatically. The Colama material, though it looks very thin, very flimsy at times, but actually it is a very tough material. So, but again, there is a limit for the toughness of the material also. And there are instances where the loading has not been done properly, where the ICL can tear. And that absolutely is because of the inappropriate loading by either the assistant or by the doctor. So it's important that we load the lens in the right way and get things right done. So if it is loaded in the right way, most of it will be very good. Now, do we believe in the quality? Yes, we do believe in the quality. It is excellent biocompatibility. And over all these years, there is absolutely no reaction of a foreign body in the eye. And that is one of the oft-asked questions by patients that, doctor, you're implanting something foreign, so will it have a reaction? The other thing that I must say, that there are certain sections of our society who ask, is it a vegetarian lens or a non-vegetarian lens? So this is actually, yes, porcine material. So you have to be, again, truthful. And it's important that you say that if such a question is asked. But what I do in the clinical practice, I ask them to do go onto the website, look into everything. So if they can mark out the porcine material, it's fine. If they don't, it's all right.
Indian lenses are not.
Yeah. So the Indian lenses are not, are vegetarian lenses. So, so about the quality of these lenses, excellent quality, very flexible, and the flexibility is one of the most important things in these lenses, and they go into the posterior chamber, which is the actual concept behind the iris, far from the endothelium. Why I'm repeating these things is because you need to be very, very confident that it is a good lens, it goes into the right place, and it will stay forever until, of course, it's explanted for reasons that are required for. So it's far from the endothelium, and you don't need to coat the endothelium with high molecular weight, viscoelastic, methyl cellulose is fine. Sodium hyaluronate is used because of the importance of getting the sodium hyaluronate out very fast and in a bolus. So sodium hyaluronate is also a substance, a viscoelastic that can be used. Now it gives excellent cosmesis. You can hardly make out. Of course, if someone is looking through the slit lamp, obviously the central flow, the opening is definitely visible. and it's close to the nodal point of the eye. There's a gain in this retinal image size, which we all understand from physiology, and the gain actually gives in these very high diopter segments, say 13, 14, 15, 16, 17, even 20s, it gives you the importance that the size becomes better for the patient, and the patient actually can improve by a line or line and a half. So it is very effective. The sulcus is a very stable location, easily removable, exchangeable. Again, I must say here that while you're looking at the slit lamp, please look at the slit lamp with dilated pupils as well. Why? Because there can be a small area of subluxation or zonular dialysis that might be missed. And these patients, definitely, if there is even a small part where there is a little bit of dialysis, definitely not to place in these ICLs. So, of course, there are no fixation issues to the iris, and it does not alter the shape or the tissue at all. So, the myopia and the myopic astigmatism, we have a timer now. So, now over the years, these spherical powers, as well as the optical diameter, the haptic thickness, and the overall height. What is very important while assessing is the importance of having a correct vault. That is first and foremost in our minds. So whenever we look at the patient the next day, the vaulting should be correct, and that's why we have to be very careful of all the dimensions that we place in and ask for the lens whenever it is ordered for. So the V4C design has a central port, and it's a very, very important designing that has come in and has stayed in the practice, and all the Indian lenses also have the same. So, of course, the prerequisites, you have to be very careful. Crystalline lens has to be clear. So if there is a PSC, a small one, even a small one, it is your prerogative to tell the patient that there is a small amount of posterior subcapsular cataract, which can happen in high myopes, and it is your choice whether you should go in, because at times these just small specks of opacity that are there in the posterior capsule will not progress, but they can, and if they do, and if it is a PSC and becomes dense, then you have to explant it quite early. So it's very important that you tell the patient, you discuss with it, and everything said and done, you have to take the decision. So the refractive error has to be stable, and this is very, very important. 6 months we adhere to 100%. Let us remember that these are very high myopes. Even at 20, 21, there might be a change in the crystalline, in the change in the dioptric error. And we definitely do not do excimer laser surgery or laser refractive procedure for patients who are now above 8 or 9. Maximum we stretch it to 9, but the more important is a phakic IOL has become such a stable and a strong IOL that we can actually place it in even the smaller diopters. So the prerequisites, 3.2, 2.8, 2.8 millimeters we have to adhere to. Endothelial cell count we definitely need to see. The ocular examination is very important, contact lens discontinuation, the anterior segment evaluation, the measures, and the angle as well as the white to white is very, very important. So again, a word about the white to white. And it is important that we measure it with the caliper and read the caliper, but also the IOL master, which actually underreads it. So we have to be very sure that both the eyes have similar readings, number one, and there is a difference of 0.5 millimeters approximately from the IOL master reading to the caliper reading, and the caliper reading is what is taken. The anterior chamber depth is also very important. Sizing provided by the OBSCAN is again very important, but the OBSCAN is very few in the market today, and we have to rely on the IOL master and the caliper readings. So we have to avoid undersizing or oversizing, and I'm coming over to the technique of the placing in the toric ICL preparation is important. You have to mark it well, and if you have a markerless system in place, that is even better. Now, just let us look at this video and the loading of the ICL. So, the important steps here are filling it with the viscoelastic, and this has to be methyl cellulose, not sodium hyaluronate at all. And it's best that you fill it yourself. And it has to be half filled with methyl cellulose, half filled with, I'll take 2 minutes. Methyl cellulose and BSS. So the ICL comes housed in the BSS, so you just have to take it out like that. Be very careful because, again, they do not supply you with an extra ICL. Now, placing it on the hub, again, is very important, and this technique is very important. You have to quickly put it into the hub and squeeze it in so that it forms a hump into the hub and it sits nicely in place. If you wait too long, it becomes a little stiff, and if it is dehydrated. So placing it in, and the wings should flange out a little. And this is, again, important. This is called the osteo forceps, by which you are actually pulling it in. So the movement should be both. You should pull out the hub, and you should pull in the lens. So then it becomes a very, very nice and a flexible way of doing it. So placing it into the hub, and whenever it is a 12.6 or 13.2 lens, then you have to be careful that the whole lens is there in the nozzle. Then, of course, seeing that it is all done under topical anesthesia, so you have to be, again, careful with the patient, and good cooperation of the patient has to be there. So inserting the lens, now both the side ports have to be made, viscoelastic has to go in, and the manipulation at the periphery has to be very, very gentle. So the body of the ICL must not be manipulated, and it is the haptics actually. So side ports done. Viscoelastic, the stream of viscoelastic again is important. So what is said is the stream should be just that it starts coalescing. So that is the optimal amount of viscoelastic inside. So when that has happened, so then you make the main port. For beginners, I would definitely say 3.2 is the desired one. And here again, it is very important to see the ICL when it is coming out, because it is this time, and you have to atraumatically hold the side port very well. And then you have to see that you can see that it is folding with the hole on the right. So forward and right, that's how it should unfold. And once it unfolds the right way, then it just gently slips in. And so it's the leading right in this, whereas in the IPCL, it is the leading left. And there's a notch in the IPCL. There are no notches here. Now, placing in the haptic into the sulcus, again, is very important. Again, very atraumatically needs to be done. Viscoelastic on top, but not to overfill. If you overfill, it stretches too much. So just at the optimal fill, and then just tweak it in. So that's very important. All these maneuvers have to be done very, very gently, remembering the fact that the zonules are there very strong, but at times they can give way also. So placing all the haptics inside, and then checking if it is a toric ICL, that the axis is in the right place. Now, we still have to do PIs if it is a hyperopic ICL. We don't do PIs whenever it is a V4C. And the centration should be good. The postoperative results are usually very good. Glare and halos, if patient complains, just let time go for neuroadaptation for that. Usually they adapt very well. The IOP check has to be done. There can be IOP elevation and the ICL vault. So we'll just stop at this. Thank you very much for your patient hearing.